thank the Professor lecture9 for his very kind invitation to this meeting. I feel honored to be here, and I'm also grateful to previous speakers for the excellent talks and introduction to my topic. I couldn't say more that every organs in our body is innervated by the sympathetic nervous system, and we have growing evidence over the last 2 decades that what was discussed previously, low body weight, obesity, inflammation, what was summarized on the last slide of Professor lecture9, and the renin-angiotensin system is related with sympathetic activity, and we have this evidence in numerous studies. I don't have any conflict of interest for this presentation, and I couldn't agree more what Professor Brian Ryan said, that hypertension pathophysiology is complex and multifactorial, involving numerous mechanisms, not only environmental factors, but also lifestyle changes, blood pressure regulation, and indeed sympathetic nervous system is closely interrelated with the renin-angiotensin system and plays a critical role in hypertension development. Why we have difficulty with treating our patient for hypertension, and again it was beautifully summarized by Professor Reiner, that every patient is different, they may respond different to our therapy, and if our patient will have high salt intake, we know this builds pseudo-resistance, they will not respond to diuretic. So we always look for what could be the driver trigger of our patient while we can get the proper response to blood pressure therapy. And we have evidence from the direct recordings of micromyography. When you compare patients with normal tension, normal blood pressure, any elevation in blood pressure is not only initiated and is related to increased sympathetic activity, but also sympathetic nervous system play a critical role in maintenance and establish hypertension, and also is elevated, increased, and associated with hypertension-mediated organ damage, such as left ventricular hypertrophy. So when we see our patient, when they operate the hypertrophy or left atrium enlarged, we know that high risk, and probably they really have this hypertension for a long time. And another method in addition to micromyography, which is gold standard technique, in mid-80s, Professor Miley Esrael developed the first method, which is second gold standard technique for measurements of sympathetic activity in humans. And what we learned from this technique, that in young patients, particularly those in early stage of the age, increased renal sympathetic activation is a prime mover for blood pressure elevation. It plays a critical role, not in early stage, advanced age, but also at early stage. The advanced age, we don't see increased sympathetic activity because it goes to increase peripheral vascular resistance, vasoconstriction, we have endothelial dysfunction, we have reduced anterior distensibility, and this is what we have hypertension-mediated organ damage and established hypertension. And increase, indeed, what was previously discussed, when we activate renal sympathetic activation plays a critical role in hypertension pathophysiology, and was beautifully mentioned by Professor Ryan, when we stimulate juxtaglomerular cells through the beta-1 adrenal receptors, and we have increase in renin secretion rate. If we stimulate alpha-1 beta adrenal receptors, we have increased sodium reabsorption, and also with alpha-1 adrenal receptors, we have reduced renal blood flow. This is the pathway in the kidney play important role in early stage of hypertension development. And we have also evidence that with advanced kidney disease, with patient doesn't have symptoms, and we heard previously, we can think about the long-term prevention for hypertension, because with every reduction in glomerular filtration rate, there is increase in sympathetic activity and hypertension-mediated organ damage. And what we have here on this slide, we have two types of renal nerves. We have those which goes to the kidney. This is the efferent sympathetic nervous system. Activation already mentioned in blood, increased sodium reabsorption, reduced renal blood flow, increased renin secretion rate. And in that pathway, which goes to the kidney, we have antihypertensive drugs. But we have now therapy which can modulate the renal efferent nerves, the sensory nerves, which are activated in response to renal artery stenosis, microvascular disease, intrarenal injury, ischemia. And these renal sensory nerves, they are not sympathetic, there's renal sympathetic nerves, they trigger integrative structure in the brain, rostroventromedullateral, which is central system integrated for sympathetic and blood pressure control, and they have increased sympathetic activation to the periphery, which we already have this endothelial dysfunction, arterial stiffness, dissensibility, inflammation, target organ damage, myocardial infarction. So we have all comorbidities associated with sympathetic activation. So what are the therapy? And over the past decade, we have numerous device-based therapies which wanted to target sympathetic activation on different level, on the kidney, but also through the chemoreceptors, barofluorescence activation therapy working directly on baroreceptors. But what we know that if we, with the renal denervation procedure, we can actually destroy these nerves working directly within the kidney, so we can abolish the signal which comes from the kidney through the ablation of not only efferent nerves, but also efferent one, this one which goes to the brain and stimulated all consequences of increased sympathetic activity. And indeed, the slide summarizes numerous device-based therapy and medical devices which over the past decades target sympathetic activation. Nevertheless, the greater interest was with renal denervation procedure, and the most studies has been done with this technique. And indeed, renal denervation revolutionized hypertension therapy in 2023 based on the solid evidence of the numerous clinical trials, including sham procedure. What is the renal denervation procedure? It's basically through the currently available system. We go through the femoral artery, and we destroy the nerves which travels and surrounded around the renal artery. We ablate them to abolish the signal of both efferent and afferent nerves. And the evidence from the clinical trials, from the second generation trial with sham procedure, show that in the presence of absence antihypertensive medication, we have reduction in blood pressure in those who have renal denervation with the blue bars compared to the green one, which have sham procedure. And based on this clinical trial, the 2023, for the first time, European Society of Hypertension guidelines recommend renal denervation procedure as a third therapy for hypertension management. What does it mean, third therapy, third pillar? In addition to lifestyle changes and also drug therapy. And currently the procedure can be considered in patients who have resistant hypertension, all patients with GFR above 40, and also if drugs treatment, we can consider also those who elicit pure quality of life or have side effects of current available therapy. And indeed, there was the game changer for interventional cardiology and hypertension management, where FDA approved in 2003 two renal denervation system, the Medtronic device, which use radio frequency energy, and the record device, which works through the ultrasound energy to disturb the nerves within the renal arteries. But we also learned from other observational studies that renal denervation may reduce not only blood pressure in resistant hypertension or in drug-naive patients who are not previously taking medication, but also other subset of patients, diabetic atrial fibrillation, reduce the incidence of atrial fibrillation, patients with chronic kidney disease, isolated hypertension, who had high-risk patient previous myocardial infarction or stroke. We have also evidence from other observational studies that renal denervation may mitigate hypertension, mediorgan organ damage, or severity of sleep apnea. And this list has been shown to have beneficial for reduction of comorbidities. But we have also evidence from our first study more than 10 years ago that renal denervation is safe and preserve kidney function in patients with mild to severe chronic kidney disease. What we for the first time did with small pilot study, that whenever we perform renal denervation irrespective of baseline glomerular filtration rate, there is preserved kidney function throughout the year, and there is no damage to the kidney, indicated that renal denervation is safe in those patients. This we observe later that not only is preserved of kidney function, but also renal denervation may hold the progression of kidney disease over the years. And in this study, when we look back to patient 5 years prior to renal denervation, you see gradual decrease in glomerular filtration rate. But when you perform renal denervation, it again holds the progression almost up to 2 years post-procedure. There was observational study, but you can see that the eGFR remains stable compared to what has been done prior to renal denervation procedure. And what we have learned also from the Global Simplicity Registry defined study, which was this observational study in a real-world setting population, when they look for those and grouped with CKD and without a chronic kidney disease based on the GFR cutoff 60. So you see here patient with CKD with GFR below 60 and those with GFR above 60. And what you can see here, the renal denervation reduces systolic nighttime, daytime, and overall blood pressure in both chronic kidney disease patient and non-chronic kidney disease, and up to 3 years post-procedure. And what you can see, there was not related to increase in medication. In other words, there was reduction in blood pressure, but also with not adding additional antihypertensive treatment, which is very important because, you know, with advanced kidney disease, we're limited with some of the drugs, particularly those who have GFR below 40, because we can't give spironolactone, even was mentioned that is perfectly first month for patients with resistant hypertension. And when you look at the same patient, what is GFR level, so irrespective whether it was patient with GFR above 60 or below, again, GFR remains stable, is preserved kidney functioning, is safe after 3 years post-procedure. When you look for the only patient who have chronic kidney disease and group them according to GFR below 45 and between 45 and 60, is comparable blood pressure reduction after the procedure and is without adding additional antihypertensive medication. And again, irrespective of baseline glomerular filtration rates, up to 1 year in this patient, you see that GFR remains stable, again showing that we can halt the progression of kidney disease, acting directly on the hypertension pathophysiology, treating at the source of the kidney level. What is another benefit of renal denervation is the durable, always on blood pressure reduction throughout 24-hour period. What does it mean? It's irrespective of patient adherence, dosing of drugs, and also pharmacotherapy. Particularly those in the early morning crisis, blood pressure is preserved, so we may reduce the risk of myocardial infarction is shown in our patient, having the constant always on effect of renal denervation in addition to drug therapy, which actually when you look for pharmacokinetics of the drugs, we have only 4 antihypertensive drugs. We have trough to peak ratio 100%. Most hypertensive drugs are short-acting. So when we treat our patient, our first goal is always look and search for the drugs with long-acting drugs with period just to prevent the morning crisis, particularly with older patients. So why we should consider renal denervation in 2025? First, we have first recommended medical device therapy for hypertension treatment, but also when you go for the first report of the World Health Organization, which was published 2023, we know that hypertension causes more deaths than any other major risk factor. That hypertension is the leading preventable cause of heart attacks, stroke, chronic kidney disease, and death. That 50% of our patients do not achieve target blood pressure. We know that actually less than 25% of those who are diagnosed with hypertension and take drugs actually achieve blood pressure level. Based on the population study, we know that they achieve below 140 over 90, but we still know that this is not our target because our guidelines said to aim for blood pressure level, particularly younger, below 65, between 120, 129, 70, and 79. This is what I wrote in every recommendation patient for when I'm treating. So based on the population, actually, when we look for this target, probably less than 10% only achieve the target blood pressure level. The other important factor is that medication adherence, but also our clinical inertia as a doctor. We often postpone the prescription while adding and changing medication. I see patients who are taking the same medication for 20 years, even including old atenolol, which is very rare use in Poland. So we have to change our medication, do this effort, and reduce the clinical inertia. But also we know that some patients, particularly those ones who are at the age of 25, and I'm saying you need to take another medication for another 75 until 100 to prevent stroke and myocardial infarction. They don't want, they prefer rather die than take lifelong therapy. And we hope to have this evidence from some studies. So what we have to conclude, that renal denervation is recommended as an adjunctive treatment option in patients with uncontrolled hypertension despite lifestyle changes and drug therapy, currently only in patients with GFR above 40. We have evidence that is safe, but it's only from observational study. So this is why currently we can perform according to the guidelines, FDA approval only in patients with GFR above 40. We know that renal denervation has durable effect and may mediate hypertension-mediated organ damage and also preserve kidney function, but we really need further randomized clinical trials, particularly patients with chronic kidney disease, because we have only from observational study.